very severe coarctation, let me say maybe near subathletic coarctation.
Do you know the number of the case?
Case 20. Which one? Which was the number?
It's
yeah.
Case 26. So for the audience that can read the details of the case. 26.
It can be presented in the audience, I think.
Okay, it's perfect. Proceed. Proceed. We can read it in our booklet.
All right.
Just proceed with the case.
Yes. All right. On my left side, Dr. Alper from Mehmet Akif Hospital, and on my back, or our back, Dr. Mario. As always, on my right side, Orhan. Now, can you see the fluoro, cine?
Yeah,
lateral and AP, please. Yeah.
We see the cine, and you can show us the measurements and the hemodynamics, whatever you have.
As you see, when the catheter crossing it, there is no passage. All passage from the collateral arteries. Let's go. Next.
Yeah, well, what we have seen that is nearly a subathletic stenosis with a minimal flow. Nicely demonstrated, yeah.
Yeah, you see when we pull back the catheter and the whole distal,
yeah.
And we may see the
we see it very clearly.
So, let's, next. And also you can see the ischemic hypoplasia.
Absolutely, yeah. And we see a lot of collaterals coming from
görüntülü ölçümleri göster. Foto. Now we are going to show the measurements.
Yeah.
As you see, distal transverse arch was measured near 17, about 16. Okay. And just distal to the left subclavian artery, we measured as on multiple measurements, 15.
Okay.
And mid portion of the isthmus, as you see, hypoplasia have, and 12. And of course, the coarctation site about 2 millimeter because of the catheter, as you see.
Okay.
And a little bit hypoplagic part, then further than coarctation, and the length of the lesion, as you see, about 36 or 39. So, what is your opinion about what diameter is balloon, what length of the stent, what kind of stent?
Okay, so I like to ask the audience, probably we start with shock. We have a transverse arch of around roughly 17 maximum. We have a hypoplasia which is going down to 12 before the subathletic segment starts, which is measuring 2, and the descending part is roughly 20, or what is it, 20 or 30? 20, roughly 20 millimeters in diameter, and the length is 36, 38 millimeter in length. Jacques, what would you do?
Yeah, starting point, this ought to have a covered stent. Then it's a matter of working out the diameter and the length, and the likelihood is from the measurements that you'd use an 8-zig 45 stent, which should shorten to the diameter, I would suggest, to 39, and that should be enough. I would be looking at implanting the covered stent on a 16 millimeter bib, but not necessarily inflating it rapidly and fully, but leaving some indentation behind, so that you're about 80% of the final diameter that you want to achieve eventually. And so that would be the way I would go.
Okay, Joe, what would you do in this situation?
Yeah, I mean, I think I would probably not go more than 12 because it's 2.9 at the narrowest point, 12 in the isthmus. You know, you have to assume that this is going to have to be done graded. Whether you go for a covered stent or not, I don't know. I would probably opt for an uncovered stent, but I would do it 12 to start with, and at a later date to 15 or 16.
Okay, let us ask the audience who would go for a covered stent. Please hands up.
Sometimes.
This is by far the majority. And who would primarily implant a non-covered
Almost
stent?
always, yeah.
Oh, that is only a single yes here. So the majority votes for
Joe,
covered
Joe
stent,
wins,
yeah.
I think.
And then we had two different diameters. One was 14 or 16 balloon achieving a diameter of let me say 14, and Joe would go with the uncovered for 12, just to make sure that the subaortic region is not dilated too significantly. And now again for the audience, who would go for a 14 or 16 millimeter balloon in this situation?
Between.
Yeah.
Well, let me say 14. Okay, let's say 16. Yeah, 16. This is only a few. Let me say roughly 10% of the audience. 14. Roughly 40% of the audience, and 12 uncovered. Just one, and 12 covered.
J1, yeah.
12 covered. Also roughly
60%.
2 people in the room. Okay, so we have two different approaches which are recommended here. The minority is the non-covered stent with a 12 millimeter diameter, and the majority votes for a 14 covered. And there is an additional question from Birgül. Can we have a microphone to Birgül?
Will they do a predilatation to make it easier for the stent to go through the narrowest part? Do they need it?
The question is, I do not know whether you heard it in the cath lab. The question was for a predilation of that region to ease the passage of the long sheath towards the ascending part of the stenosis. Please, you can comment on that. And there's another question here in the back. Could you comment on that predilation of the region just to ease up the passage of the stent of the sheath?
Yeah, it can be done for easy passage, but it is not necessary. I usually prefer predilation with 4 millimeter or 5 millimeter balloon, but it is not necessary because we have dilator and we have just crossed easily. Now we are at the arch. We haven't encountered any problem now.
Okay, let's raise this question for the audience. Who would predilate it to ease up the passage of the long sheath? Okay, we have a change in mind. So no one would predilate it, because with the use of the sheaths we already have available, together with the wire, which is according to the inner lumen of the dilator, we think we should have a smooth passage over this subaortic lesion. So no predilation as a vote from the audience.
Right.
So now up to you. What have you chosen, and what is the approach? What you're going to do now?
Yes. We have chosen balloon as balloon up to on my shelf. In fact, we decided with discussion among us 15 millimeter balloon in balloon and 4.5 centimeter in length. But
Okay.
we haven't.
It was 14, is it right? 14 millimeter balloon?
No, 15 millimeter
15,
balloon.
okay, 15 with
And,
45 in length, and that means that you have
by
chosen the stem.
by 4.5, but we haven't.
Yeah,
Of course, there is no doubt about it that covered stent must be used in this kind of patients.
Okay,
Must be, yeah.
what
No,
length?
no doubt about that.
What length of a stent? And what kind of a stent? You're
Of course, taking into consideration of shortening, that is more than the under stent, as you know. So up to table, 45 millimeter length stent shortens after dilating with a 15 millimeter balloon to 38, like this. 38 like this, near 39 like this.
what
So,
balloon you're going to use?
That is right, that we are absolutely agree with Shock about that.
Yeah, Felix, it's Mario. May I make a comment on that?
Yeah.
Well, you heard your comments on all the audience. More or less, there is agreement to put a cover stent.
Yes.
With the balloon ranging between 12, 14, 16. Well, we would like to use a big balloon in this case, but we don't have the big balloon long enough. So Ahmed decided to use a ZMed balloon, 15 millimeters in size and 5 centimeters long.
Yes.
Yeah?
And you are going to mount a covered stent which is 39 in length. Is that right, or is it?
No.
No. 40.
45 millimeter
45.
in length. When
45,
Yeah,
shortens,
45.
when shortens to
Okay, that's
It's
39,
like the
yeah.
shorten. Well,
I
Ahmed
think
has
that's
already
reasonable
put a 12 French long sheet across the coarctation, and now he's sitting in the above the coarctation. So I think, Ahmed, you are ready to.
Yeah, Alper
go ahead.
will put the stent. As you see, covered stent, we use always the
We have
plastic
to.
tube
We have
on
to see the
it.
table now.
Yeah, please
There is-
focus on the table now.
Yeah,
Yeah.
focus. Alper, you can show. Always we cut this because it may be long, then we can't go at the end of the balloon or out of the sheet.
Yes.
So
yes.
we cut always.
Okay.
That's the covering for inserting the balloon with the cover stent.
Yes.
Okay.
After
This will
insert it,
prevent slipping the Gore-Tex tissue from the stent.
and
How big
also
is the
enlarge
sheath
it
you're
with a-
using?
The sheet, the long sheet is a 12 French cook sheet.
Okay, so it's far
go.
big enough.
Yes. You see the fluoro now. Let's
No, we
switch to
don't see.
fluoro.
Please
Let's
give
switch
us
to
Fluoro,
fluoro.
please.
Fluoro large
lateral
Wait a
and
second.
AP.
Fluoro large screen.
Let's
please.
switch to fluoro.
Not hand. Fluoro.
Oh yeah, that now we.
Double fluoro.
Okay, here was one
Lateral
comment
and AP.
from my colleague whether we should discuss
Lateral bigger,
whether this
please. Lateral
stent
bigger,
can be
please.
a bit too long. Can you comment on that, please?
The stent is too long. Well,
That
in my
is,
opinion,
that is a question
it-
that was rising up.
well, I think it is not too long. I mean, we know that CP stent will shorten a bit. We have a long segment of isthmus apoplasia, about 2 centimeters. So I think this is a good size, a good length of the stent. What do you think, Felix?
Well, I personally would take the same length of the stent, and where you want to start the inflation? Where is the distal part, the proximal part?
Okay.
Well, I think what I would do, that Ahmet will decide. I'm not scrubbed here. I think the risk of dislodgement of the stent with tight cord like this is very minimal. So we don't need rapid pacing, for example.
I think 0.
And we will place the stent and check by hand ejection through the side arm of the sheet where the balloon and the stent is, and then we'll see.
You can
Well,
go
the most
a little
important
bit up.
question
What are
for
we
the
looking
doctor
at?
is,
We need the same.
To
No, step.
Go.
No, this is not.
This
This
is
is
good.
not the same. This is not the same projection, Ahmet. Yes.
Lateral. It's
Okay.
okay. No problem, yeah?
But
where you start
we have to have the reference point.
Center.
But please
We have
give
to
us
have the
any-
reference point.
Yes,
Ahmet,
we
what
have.
is it?
This is good place.
Okay.
Yeah.
Can you give us
No doubt.
any information what you
Tam,
decided
biraz daha.
where to
Tam,
place
tam,
the
tam,
stent
tam.
with
Yarısından
regard to
biraz daha
the
aşağı gel.
entrance to the
gelmesin
left
lazım.
subclavian artery?
Yeah, Felix, there.
Yeah, we are gonna do an angiogram after uncovering.
Well, I would
up to
suggest
half of the stent, yeah.
that the stent should be expanded
Bana bile gerek yoktu ama neyse.
right at the origin
this is
of
the
the subclavian,
Right.
which is a huge one. I think
Absolutely.
maybe I think it is in the correct spot, maybe 2 to 3 millimeters back. What do you think?
That's right. The reason why I ask is the hyperplasia of the segment
yerin
starts
belli, şeyin
at the
ortası,
part
hepsi
where
çıkar.
the subclavian artery
Yukarıda
Yes.
belli.
arises, and that means if you
Wait
would
a
have
minute, wait a second.
dissection there, you will not
Last
have the
injection.
coverage. at
Yeah,
that
that's
part.
right. We would like to cover, yeah, I think it's reasonably good position now.
I think, yeah. Let's do another
Well,
injection.
another
Taking into
important point is
consideration
that if the
distal
stent
part.
will shorten too much,
Yeah.
we will have a discrepancy of the distal stent of the descending aorta, which is much larger.
Yeah, that's right. And especially if you're going to dilate it further during follow-up, you probably will have a foreshortening, which is significant and will.
I think we
no-
don't need this because
Yes.
this patient 33-year-old.
Yeah, okay. There's
Well,
a
but-
comment from Jacques.
It depends of the immediate hemodynamic results, and it depends whether Ahmet, you are going
Sen
to
biraz daha aşağıya.
dilate
Bak daha yerin şey değil.
the stent to the full size or be more conservative, as Jacques was commented,
Hah, güzel yerin.
to go up to 12 millimeters. Is that right?
Bas, kaydederim.
I do not mean
Kayıt al.
redilation in this setting, but also in the long-term follow-up.
Yeah, yes, I know,
Biraz
but
aşağıya gel.
Jacques,
I
you
mean-
have a comment.
Felix,
One technical point here,
they are
and that
concentrated.
is related to sheath angiograms with the
okay.
stent inside.
Okay.
Yes.
Join now.
And that is that if you do a very hard
We
injection,
are gonna inflate now.
yeah,
No, do not repeat it, because Jacques I may anticipate him. If you
Yes,
do
yes.
a strong injection without inflating the inner balloon, you may get the tissue of the cortex
the covering comes off or can
comes
come
off.
off.
That's right. That's
Yeah.
why I will avoid, Ahmet,
Yes.
I think you're in the good position. Why don't you go ahead and deploy the stent there?
In this situation, it's the best decision you can make.
We are
you
at
know.
good position.
Because the covering is attached by glue.
Yeah,
at
that's
2
right.
points at top and 2 points at the bottom.
not-
And if you take one bit off, then it will detach.
I think the position is okay. Go ahead.
Yeah.
Yeah, go ahead and deploy the stent. Go. Yeah.
Go.
Oh, well, I will go, yeah, up to the full, yeah, that's okay. Good,
Okay, you achieved
Okay.
full expansion.
yes.
Was this accidentally or?
No, we wanted to deploy fully
Okay.
If there is
instead of Jacques' suggestions.
I would have done the same. With the 16.
even if there is aortic atresia, I mean isthmus atresia, I inflate
Well,
up
maybe.
to ideal diameter because
So-
we have
okay.
covered stent.
So we do an angiogram, yes, now.
I think it is not.
We can
necessary,
advance
huh?
the sheath across the stent.
Let's
Be careful not
okay,
to
okay.
dislodge this. While advancing
it's
the
okay.
stent is rather, you have to be careful not to get impinged into the
Do you not
stent.
want to sculpt the top first
Exactly.
and then do the angiogram?
Yeah.
Yeah, that's right.
Yes, let's go.
You do an angiogram here.
I think not exchanging the wire. It's,
Why don't you do just a quick spot now before, well, it's
Okay,
up to
we
you.
have not.
I think after.
Yeah,
have not decided to have a quick spot now because
Quickly.
he's already retrieving the balloon into the catheter.
no,
The reason
I-
why this
yeah,
is,
that's right. You have a
probably-
balloon just to inflate partially the balloon and using the balloon as a dilator.
We will do with a pigtail, and
Or,
I think it is better
Or pulling.
in a few seconds.
No,
Yeah,
I mean,
and
the balloon is okay.
same
I mean,
balloon.
It's
Well-
very hard for us to understand who really wants to say us something. Could you please just speak just one person per
yes,
second?
Ahmet, they want to know what you're doing. So nobody else will speak, just you, Ahmet. Explain what you're doing.
Now we have extraviorals. We removed the balloon, and then we are advancing the pigtail catheter to do an angiogram and also simultaneous pressure recording.
No, sorry, Ahmet. You
What?
cannot do well, you have to remove the wire if you want to do an angiogram,
Of
yes?
course.
Okay.
Just
so,
now we arrived,
right.
so
Okay.
we
If
will
you
do
like, yeah.
of course.
Well, if I were you, I would leave the wire, advance the long sheet, and do
Can we see the
an angiogram through the sheet. And we thought, because I don't want to remove the wire just in case. Yes? But anyway.
Yeah, well, I think if you have a pigtail placed in the transverse arch, you have an access for the wire in any way. So
Yes, we have an access anyway.
Yes.
Yeah, so you do an angiogram with the pigtail.
Can you give us a simultaneous hemodynamic pressure measurement?
Bu arada
Well,
diğer bir arkadaş ikinci
Ahmet,
pressure
they
yapsın.
asking to see simultaneous pressures
Yeah,
in
yes.
the pigtail
Yeah.
and in
İkinci
the
basınç.
side arm of the sheet. So
Yeah,
we can
because
have a
we are not ready for simultaneous pressure, so we do angiogram after that.
All right.
Yeah. In a few seconds, yeah?
So,
Yeah.
okay, you're going to perform the angiography first, and then we have pressure measurements.
Aynısı. Basıncı değiştir o arada.
It's a pretty stable
Yenisini tak,
position
eskisini
of the
değiştir.
stent. Nicely
Hazır
silhouetted.
mısın? İyice biraz yaklaştır çünkü artık stenti görmek istiyoruz. Arkası değil. Ha, şimdi güzel. Very good.
Hazır mısınız? Tamam.
Very
hadi
good.
Görünce ver.
Very good. Perfect.
Ahmet, I'm
It
going.
looks like major.
Yeah. Let's show the
Is there anybody
simultaneous
that
pressure.
can get me to the
İçinde şey var.
conference room?
İçinde bol miktarda şey var.
I have to disconnect this.
Okay, I know. We are going to show the
Yeah, please.
simultaneous.
One comment from Omar, please. Stop.
No, I just want to ask the colleagues, would somebody have thought to leave some indentation? Like for me, I feel much safer if I leave some indentation and later can go in after 6 months, 1 year, and then do the full balloon. Just to make sure
Şunu yüz
the
yapsana
stent
ya.
does not move.
Ya da
Have you heard this question?
Senden,
Okay.
bir de senden.
Super.
Mario and Ahmet,
Yeah,
have you heard these questions?
Yeah, Mario has just removed for the presentation. I am here.
Okay,
I
Ahmet.
couldn't understand. What was the
Okay,
question?
the question was, why not having a indentation in a stent during balloon inflation and having the expansion of the stent in a later step?
Yeah, Alper disrupted the angiography during inflation, so we couldn't see. At the end of the inflation, he pressed on the cine, and then you couldn't see the west. It was the. Did you understand?
No.
Let's see the angiogram. Ballooning, please. Ballon. Show the ballon. You see?
Yeah,
There is no record.
that's right. There's no real recoil, but the question was that you expanded the stent up to the fully diameter of the balloon, and Omar questioned.
What?
Omar questioned this whether it should have been
Lesser.
a better approach to have any residual indentation
No.
instead of achieving the full diameter.
No. My approach is even I have experience in 4 patients totally obstructed isthmus and also 3 interruption that I am gonna show late afternoon. Even in them, I fully expanded and I haven't any problem. Also, subatragic patient also, I have more than about 10 patients. My preference is to dilate up to ideal diameter. Can you see the pressure?
Now we
Pressure,
can see.
pressure.
Yeah, now we see the pressure. Yeah.
Yeah.
It seems that
Identical, as you see.
it seems there is no gradient if this is an overlay.
There
of
is
two
no gradient.
curves.
There is no morphologic problem in angiography, I mean. So why don't we inflate up to ideal diameter, and why it is obligate? Why do we delay the next intervention, of do we delay the ideal result?
So you want to go for larger diameter, is that right?
Yes, ideal
No.
diameter. Yeah?
Felix, the point I was making about leaving a waist previously was that in this particular patient, the post-stenotic area is not as hugely dilated as we come across some. And so if you get a dissection, you're going to get the dissection in that relatively uncovered part of the stent at the narrowest point. And there, if you leave an indentation, allow that area to heal and then redilate 6 months or so later, then it's probably safer. I've got one example of that where the distal part, there was a big dissection. So that's the reason.
Well, I can give you an anti-example.
Yeah,
where
Shaq,
we
I would
just,
like
did it as you
ask a
described,
question.
and we had a rupture, a dissection, which is tending to the area which is below the indentation we left, and then we had to push up with the second balloon the lower part to cover it again. So I think in both ways it can happen. So yeah.
Yeah.
Ahmet,
Let me make a comment. Yeah, a few minutes, please. If there is shock, if there is any rupture or dissection, what do you do? Of course, you put a covered stent. So it is the treatment of the rupture. So we cannot expect at the central part. In fact, I have encountered in two patients with limited dissection at the end of the stent because of the flaring of the not covered part. Can you understand me?
Yeah, absolutely. It's a good
So
argument
the
for your
problem is
approach.
that I always choose in these patients. In fact, I am not satisfied this 5 centimeter in length balloon,
Okay.
but we have not. I choose always not more than the stent length balloon, sometimes 0.5 less than that, because I fear flaring of the cover stent at the end and then cause rupture at the end.
Yeah.
Yeah.
There's one question again.
Not question, comment. The problem in this particular position, we don't know when we inflate the balloon how the dead tissue will react. Sometimes very resistant, sometimes just like a membrane goes back. So when you use cover stent, especially, because otherwise it can be embolized side, go down and
Bir öncekine dönebilir misin?
Okay.
Bir önceki.
This is not a problem.
This can be a
Bir
problem.
öncekine gelebilir misin
So
balon?
I
This
just
is very good.
agree with the chef. It is better to a little bit oversized balloon, to use oversized, but control circulation. And if you see the wasting, not stop there, not to go too far. And also, the narrowest part, the proximal part is in this patient was about 13 or 14.
Bizim
So
işimiz.
it is
It's identical ondan sonra. There is no rupture, dissection. Excellent outcome.
Exactly, all the standards.
Congratulations.
Okay. Ahmet,
Alper.
what is your plan now?
Yeah, the voice was very low. I couldn't understand.
Well, okay, it was just a comment that there are two approaches. That what you used with the 15 to the planned diameter, and the other comment was with regard to having a slightly oversized balloon, but not with the intention to achieve the fully diameter during inflation, just to have a residual indentation of the balloon. So, but I think either way may work in this situation, and you demonstrated a very nice case. And but at the very end, what is your plan now? Are you stopping it? So is end of procedure?
There is any indentation? Yeah. If there is no gradient, stop. If there is gradient more than 10 millimeter mercury, I redilate.
Okay, that means
In native coarctation, I haven't encountered in ideal diameter of the balloon. But in recoarctation, almost always there have been an indentation. In surgical recoarctation, I mean, not balloon. Due to balloon.
Well, that's what we understood. But
And
what is,
even if there is no gradient, zero gradient,
yeah.
you may see indentation on the stent in surgical recoarctation.
Yeah, okay. But
So I don't do anything because there is no gradient.
okay, that's perfect. So I think we have a really excellent result in this situation, and it was nicely and perfectly demonstrated. And no gradient means no further step. That means get out of everything out of the body except the stent. Okay, thank you very much.
Thank you very much.